Hello, dear friends, dear doctors. Please subscribe our channel for motivation of more making videos. So the topic is endometriosis today. The endometrial tissue outside of the uterine is called endometriosis. So the etiology is not fully understood. So the mechanisms which are suspected uh, for having endometriosis is retrograde menstruation, the immunological factors, metaplasia of the coelomic epithelium, and extrapelvic diseases. So this situation mostly happens in between 25 to 30 years, and it stops after the menopause. Actually, don't worry about some extra like information which is present here. Um, I added by myself this informations. It's only for my understanding and my transmission from Russian to English. I need to mind my English. Okay, we're going for the situs. 60% of the patient have ovarian involvement and broad ligaments and vesicoperitoneal folds and etc. Uh, so we are going for the clinical features. First of all, pain, and second is infertility and mass. So the pain can appear as like menstrual symptoms or bowel bladder symptoms, and it's irradiating to the back. And actually, frequency dysuria and hematuria also can be happening. There can be diarrhea and some other symptoms, constipation, uh, in this case. And about the infertility, 50 to 30% of the patients who they have infertile will have endometriosis. And we're going for the third clinical feature. It is mass endometrioma. So during the palpation, you will feel it in a physical examination. So ovarian mass can be present with any of the above symptoms or be asymptomatic. Okay, we're going for the investigations. Investigations are they're more invasive. As I heard about it, you can do ultrasound also, but it can be not showed because the size can be really small, and it depends on the physician which is doing the ultrasound also. But the more definite is laparoscopy method and getting biopsy. Uh, that will be the most accurate one. In the laparoscopy, you will see mulberry spots, dark blue, brownish, black. So I add some here photos like about the endometrial like tissue growing within the myometrium. Here it's located, but it is not actual one. So here is hemorrhagic powder burn lesion. Also we have such a picture inside of the peritoneum. So it's something like that approximately. So we have it in a laparoscopy powder burn lesions on the peritoneal surface, or white lesion or peritoneal pockets. Okay, so the next will be suspected endometriosis. We need therapy by contraceptive methods that contains both an estrogen and progesterone. So if the first line is like collapsed, we are going for the second line. The second line is gonadotropin releasing hormone agonist was add back, or second progestin IUS. The laparoscopy is going for diagnostic and treatment in this case. So another time, let's look at this hemorrhagic powder burn lesion. This one is lesion, but the actual one is just spots, I think. Powder burn, no, it's the same, sorry. So we are going to the treatment. Here we have treatment. Surgical confirmation of the disease is not required prior to starting medical management. So first of all, we are going to diagnose it. After the diagnosis, we are going for medication therapy. I mean medicamentosis. Asymptomatic endometriosis does not require the treatment. Management depending on the criteria of the diagnosis, severity of the symptoms, extent of the disease, desire for future fertility, and impact to GI and GU system. So medical therapy is NSAIDs like naproxen, and first line it's cyclic continuous estrogen progesterone, oral contraceptive therapy, and progestin. It can be in the form of IM, intramuscular, or we can put Mirena intrauterine device, or second line is gonadotropin agonist and danazol. So the last one, which is a little bit radical, it is surgical conservative laparoscopy using laser, hysteroscopy plus bilateral salpingo, oophorectomy, and etc. So mostly I think we are going for the medicamentosis, and only in the last we are doing surgeries, and most of the cases are not needed to do surgery for them. So here's for today. Thank you.